All right, Landon, hit the disclaimer.
The reason why I say that is if you look, even compared to the bone health drugs like the Prolia, the Reclass, like these big gun drugs, the improvement in bone mineral density in the studies that exist in the right population are very impressive. And this is not something that is a short-term fix, right? The bone health drugs you can only use for a limited period of time. Estradiol you can use, for postmenopausal women until there's a compelling reason not to, or indefinitely. And so this is a long-term fix, which is just as powerful, and in many of the studies, just as powerful as a bone health drug and can be used long-term. So but that is for optimized HRT, which is different than using the lowest dose estradiol patch and hoping that it's doing something good for your bones. So there's nuance to this, but estradiol, hands down, one of the best tools we have. That's why it's FDA approved for prevention of osteoporosis, but not for treatment. Testosterone is not as well studied. Testosterone, I've seen like 2 studies, one intervention study where they added it to an estradiol pellet and oral micronized progesterone. It did outperform the pellet and progesterone alone, but it was a small study a long time ago, and that's about the best we got. Testosterone has been studied in men more, but even then the numbers were small, the studies were short. They showed improvement in bone density in some, but not all, but no fracture risk reduction because they just weren't big enough to detect it. Not the right study design. So we can't say by how much testosterone helps bone, but what we can say is that anecdotally, I'm sure you've seen it, I've seen it, for both women and men that start testosterone therapy who have osteoporosis, boy, it sure gets better.
Yeah,
So
exactly.
I really do think that it is a powerful tool. It's just hard to put numbers on it because the research around testosterone just sucks. I mean, call it what it is. That research sucks. So it's not great. And then progesterone is even worse from a research perspective because it's almost never studied alone. So there isn't a single study that looks at just progesterone therapy for bone health. Like, what does it do? So I look at progesterone like it's always the co-captain to estradiol. Like it's not never. It is sometimes, but it's rarely studied alone. And we know that bone has progesterone receptors, right? We know that the brain, we know that, obviously uterine lining, the breast tissue, like there's progesterone receptors all over the body. So it would make sense that it would have a positive impact, especially in cycling women. We know that that's true. What's the impact for like a postmenopausal woman if she were to just take micronized progesterone alone? Don't know. I think it's good for your bones, but I can't tell you by how much. So the combination though is powerful. We know for cycling women, if they're not ovulating, if they don't develop good progesterone endogenously in their luteal phase, they're going to lose bone. So we know that it's important for bone. I just can't put a number on it.
Sure. With hormone optimization, symptoms guide a lot of my treatment, but I do think like vasomotor symptoms can be controlled with relatively low doses of estradiol. But I've seen stuff where their levels need to be at least 80 to 100 to get optimal, bone health and everything. Are you using numbers to guide, or is there an actual number threshold that makes a difference with bone?
Yeah, so I'm a big fan of measuring. I love looking at biomarkers. Again, I think data really helps us drive decision making. I've been not impressed with how consistent estradiol is from a level by itself. So we used to look at this like we had our range, 60 to 80 was our range. And what we found is that we would have women who had very low levels of estradiol, like 15, 25, and their CTX would drop and we would see them improve. And that's all they could tolerate, right? So we could never ramp it up. They would get symptoms, and the symptoms we couldn't control, or they couldn't, tolerate more progesterone, or like whatever the reason is. And we saw them get better. Similarly, I've seen women that have estradiol levels over 100 doing great from a symptoms of, VSM, GSM perspective, but still losing bone. And so what we've done is we started looking at all of them together and we say, okay, like what is your serum estradiol? What is your FSH? What is your CTX? What is your P1NP? And when you look at all of them together, now we start to understand what's happening at the cellular level on the bone. Because if a woman has, let's do the low example, right? So let's say a woman has a serum estradiol of 20, but her CTX is low. It's under 200. And her FSH has been suppressed. And now her FSH is 20, right? Like I have a hard time telling her that she needs more estradiol, unless she's symptomatic. But looking at those numbers, I'm like, nah, I wouldn't raise it, right? Like, what are we going to do? How are we going to help you more? Um, and the opposite's true too, right? So a woman has really high estradiol, really high, whatever that means, 100, 120, 150, whatever that is, right? But her CTX is still high, right? Her FSH is still 100. She's not getting it at the serum, at the cellular level, right? There's something happening there. So then I would actually, for that patient, I would ask, like, did you, is this a cream? Did you apply it on the same arm as you had your blood drawn? Like, I don't think that those numbers are real. I feel like something's off. And this is how it helps to guide us. And so there isn't a single estradiol level that we're looking for. It's kind of the big picture. And then we're looking for kind of the outliers, like that last example. Like, I think she probably put cream on her arm and then stuck a needle through it and drew blood. Like, I think
Okay.
it's too high.
Yeah. Can you? I'm not real sure. I'm not following FSH for anything with mine. Why? How is that guiding you?
Yeah, this is kind of an interesting one. I've seen a lot of data around it recently. I learned about FSH when I was learning about there's a whole movement around cyclic hormone therapy for postmenopausal women, right? So all the way from just cycling progesterone, which used to be, standard of care, to actually, a rhythmic protocol where you are actually raising and lowering estradiol and then raising and lowering progesterone. This idea of actually recreating menstruation in postmenopausal women, which is a whole other topic. But in that, they measure frequently estradiol, progesterone, FSH. And the reason for that is that we can get a sense of what's happening at the cellular level if FSH is coming down. Because if you think about what is FSH, follicle stimulating hormone, what is it? Well, it's your cells telling your brain that they want more estrogen, and then your brain sends FSH down to your ovary, a woman's ovaries, not yours, a woman's ovaries, and it's going to stimulate secretion of estradiol. So this is the feedback
Gotcha.
loop.
Gotcha.
So then if the cells are still starved for estradiol, then FSH is still going to be secreted by the brain, and it's going down and it's talking to the ovaries, but the ovaries aren't listening, right? This is the postmenopausal feedback loop, or broken feedback loop. So then if you apply exogenous estradiol, it's going to have an impact on that feedback loop. And we'll see women's FSH go, from 90, 100 to under 30. And this is when we start to see everything kind of line up, right? We start to see like the lipids get better. We start to, their symptoms are definitely better at that point, right? But it's the early symptoms, like vasomotor symptoms for sure are better. But then they start noticing other things. We're like, man, like my sleep is really good. I'm getting really great deep sleep. I've got so much energy. I feel so much better. My libido, yeah, it was better initially, but man, now it's actually really good. Like it's good as it was when I was in my 20s and 30s. Like that's when we start to notice these really profound changes with these hormone levels.
And then on the topic of hormones, I want to talk about thyroid optimization. Like, because we'll frequently try and bring a free T3, from the mid twos to, 4.5 or the upper end of normal. But is thyroid on the upper end or optimization, is that harming bone at all?
Yeah, there was just a study that I recently looked at on this. I think it was a publication from this year, because and this is important because there are, if you just Google it or you ask AI, it'll tell you that um, the synthetic drugs, T4 only therapy, is associated with poor bone health, right? If you look at oversuppression of TSH is associated with osteoporosis. So there's these associations that are out there. But what this recent study that I reviewed did is they looked at people who had hypothyroidism who were being treated, which is important because I think a lot of the associations are people that actually have hyperthyroidism
Yeah.
from another cause. They have Graves' disease, and they're like, oh, they have osteoporosis. Well, yeah,
Yeah.
but that's not what we're talking about, right? We're talking to people that have hypothyroidism who are being treated with whatever therapy and is that therapy associated with bone loss? And the answer is if you keep their TSH, which isn't my favorite biomarker, but this was an endocrine study. So if you keep their TSH above 0.3, and I forget what the top end was, I think it was like 4 or whatever. But in that broad range, then there was no impact on bone health. If you got, I think there was, I'm trying to spend a minute since I read it, but I think there was a level under 0.3. It was like 0.3 to 0.1, and then it was like ultra suppressed, right? Like the 0.0001. And even in that very low range, there was no negative impact on bone. For those that were highly suppressed, meaning their TSH was essentially unmeasurable, there was within them a lot of heterogeneity, meaning that some of them were losing bone, some of them were not. And I think the reason why we see that is that if you look at some people who are pulling really hard on the thyroid lever, right? They're using big doses of thyroid. I think oftentimes you can cover up other symptoms, you can cover up other things that are going to potentially predispose to bone loss. So I interviewed and I've spoken frequently with a guy, Dr. Robinson. He goes on Instagram by the Sex Docs, and he's a hormone guy, thyroid guy. He's written multiple books on the topic, and they pretty frequently will suppress TSH pretty darn low. He was like, universally in my patients, we do not see bone loss, even though their TSH is highly suppressed. Another Amy Horniman, another friend of mine, she goes by the Thyroid Fixer on Instagram, right? Like her entire practice is thyroid, and very frequently, again, suppressing TSH, being very, very low. Her patients are not losing bone. Why? Because they're optimizing other things, right? They're optimizing hormones. They're optimizing estradiol. They're probably I know John Robinson's optimizing testosterone. He loves testosterone. He's got a brick and mortar clinic, right? So if you optimize the other pieces around it, I don't think you're going to see bone loss. I think if you're pulling really hard on the thyroid lever alone, you might be in danger. And this is why like optimization needs to be a comprehensive look, not just a single lever look.
Yeah.